Thank you, and welcome to the ACIP meeting. We're very fortunate this morning to have Dr. Tom Frieden lead off the meeting, provide opening remarks, and welcome all of our audience participants, including our new members of the ACIP. Dr. Frieden.
Thanks very much, Larry, and welcome to all of you. Welcome to CDC, and welcome especially to our three new members, and you'll hear more about them from Dr. Pickering in a bit, Dr. Allison Kempe, Ms. Cynthia Pellegrini, and Dr. Reingold. I also want to welcome our international visitors from Japan and China, and those who are listening in on bridge lines and other means of tracking what we're doing. And I think one of the fundamental concepts of ACIP, and one of the things that's so important, is one of the essential principles by which CDC operates: to base all decisions on the highest quality data, openly and objectively derived. That doesn't mean there'll always be unanimity of opinion on what should be done, but it always means that we'll be transparent about the decision-making process, about the data that goes into that decision-making process, and about the thinking that goes into the decisions and the deliberations that we have. And I think the ACIP is really a model of that. In order for progress to be made in health, we need to have collaboration between the public sector and the private sector. And we need to have safe space for that to happen. And the ACIP is a safe space for that collaboration. And if you think about the vaccine schedule, which is one of the things that you'll be discussing and in fact voting on today for kids, discussing for adults, that vaccine schedule is a way that we are literally, as one country, on the same page on vaccination. Now, it doesn't mean that there won't be deviations from that schedule by some clinicians and some parents and some reasons, but it does mean that there's a standard that's been openly and objectively derived. And I do want to say that we are so delighted not only that you are here, but we're at least as delighted that we are here. The shutdown was very frustrating and very challenging and very anxiety-provoking because we were not able to keep all of our commitments to our partners in this country and around the world. We were not able to maintain momentum on some of the programs that were scaling up, like HPV vaccination. We were not able to track diseases as intensively as we have in the past, such as flu. And we're very grateful to the commissioned officers who pinch hit and did some of the preparatory work for this meeting, as well as much else, everything from pipetting in the laboratory to feeding lab animals. Commissioned officers were not furloughed because they're part of the uniformed service and the public health service. Now, we know that vaccines are one of the great success stories of the past 100 years. And we know that there are enormous achievements, and we know also that the return on investment is phenomenal, with about $10 in societal returns and about $3 in healthcare returns for every dollar spent on vaccines. But we also know that there is unfinished business in vaccination. And we know that there's much more that we need to do. But we also should, I think, take a moment to recognize that this is a very special anniversary. It's the 20th anniversary of the Vaccines for Children program, the VFC. The VFC is truly one of the great success stories of public health in this country. It's easy sometimes to take it for granted, but it didn't just happen. It happened because of a lot of hard work and advocacy and data and involvement of groups outside and inside of the government. The VFC has virtually eliminated health disparities among vaccination rates among our nation's kids. And that is remarkable in and of itself, and it's remarkable as an example of what can be done to reduce health disparities. It also got kids vaccinated in their medical homes. This was a big problem before VFC, but it reinforced the medical home through another type of public-private partnership. It was good for kids, good for parents, good for providers, and good for the community. Now, there's a lot of areas in which we can make more progress, but one I want to mention in particular is the HPV vaccine. Now, I've cared for women who've died from cervical cancer, and I think of them when I think of where we are with HPV. There's been some success. Recent data shows that the infections addressed by HPV are down by more than half since 2006, and that's progress. But we know that we're still at only about 1 in 3 girls fully vaccinated in this country. Now, Rwanda is at 85% or higher. If our vaccination rate was that of Rwanda, there would be more than 50,000 fewer cases of cervical cancer among girls alive today aged 0 to 12. And for every year we delay, it's 4,400 more women who will get cervical cancer despite pap smear screening. So we do need to do much better. We're used to a scale up when new vaccines are introduced, maybe about 10% per year increase. The most recent year for which we have data, 2012, there was no increase in HPV vaccination rates. So this is disappointing, and we need to step up our efforts to protect kids. This is an anti-cancer vaccine, and we need to really make that point clearly. I really want to thank all of you for being here, for your attention to detail on the materials. We really appreciate it. We know you're all busy. We know you all have competing demands, and we appreciate everyone who contributed to this meeting. And of course, it is the time to remind everyone to get a flu shot, and to have you make sure that all of your patients get a flu shot and that all health workers get flu shots to protect not only ourselves and our families, but our patients as well. So thank you so much for what you do, and we look forward to the results of your deliberations. Thank you.
Our thanks to Dr. Frieden for the comments. I think we will move to the opening comments from Dr. Pickering.
Good. Thank you, Dr. Temte. Good morning and welcome again. And again, we really appreciate Dr. Frieden being here and opening our meeting. It's really very, to me at least, very, very invigorating. The proceedings of this meeting will be accessible to people on the World Wide Web, so welcome to all of those out there who can't join us in person. Hopefully the next meeting you'll be able to attend, at least some of you. Several people will be with us for the duration of the ACIP meeting to assist with meeting functions, and we really owe the following individuals a special thanks, because as Dr. Frieden mentioned, during the shutdown, it was very difficult for them because they couldn't complete their work, but came back and did complete it in a yeoman manner. Felicia Betancourt, Natalie Green, Reed Walton, and Stephanie Thomas, and Chris Carraway on the computer. And I'd like to especially thank Dr. Gene Smith, who is a member of the Commission Corps, who was here working with Dr. Shuckett as yo people on getting the meeting together. And without them, this meeting would not have been possible. So both to Gene, thank you, and to Ann, thank you. We have a full agenda today and tomorrow until we adjourn approximately 5:45 if Dr. Temte keeps us on time today, and about 1 o'clock tomorrow. Coffee with breakfast items as well as box lunches will be out in the foyer. Handouts of slides to be presented have been distributed to the ACIP members. Handouts are on the back table, and of course the slides will be posted approximately 2 weeks after the conclusion of this meeting. The live webcast videos will be posted about 4 weeks, and generally we have our meeting minutes posted about 90 days after the meeting completes. The agenda for the last meeting have not been posted because of our 3-week delay, but will be posted fairly soon for everyone to view. Members of the press who are interested in conducting interviews with ACIP members should contact Jamelia Howard-Jones or Jason McDonald for assistance in arranging the interviews. I saw Jamelia earlier. She'll be back there. So any help or assistance that Jamelia or Jason can provide, please contact them. She's over on our left against the wall. At this time, we welcome the 3 new ACIP voting members for whom this will be their first meeting. And Dr. Tempe will introduce our 3 new ACIP members.
Thank you very much, Dr. Pickering. Going to just start out with a couple quick comments. And first of all, next slide, please. Congratulations to Larry. He didn't know this was coming. We just jumped this on. But at the ID Week in San Francisco 2 weeks ago, Dr. Pickering received the Pediatric Infectious Disease Society's Distinguished Service Award for outstanding contributions in the field of pediatric infectious disease. And I'm going to just read from, I have my copy here, and Dr. Pickering featured in here. But through all these endeavors, Dr. Pickering's passion and energy have improved the lives of children throughout the United States and the world. Perhaps his greatest impact on global child health has occurred since 2005, when he was named as the ACIP's Executive Secretary. The ACIP determines all the vaccine recommendations in the U.S., and Dr. Pickering has expertly guided this august organization to a position of global prominence throughout the world, through worldwide collaborations with counterparts and countries on every continent. I think the number of visitors we have here from across the world is a testament to that as well. So just congratulations to Dr. Pickering. Next slide, please. We have introductions here, and next slide. First, Dr. Allison Kempe, and I have to toss out, I just have to do this, it's Kempe with a P, not a T, just because I have to deal with the other way around all the time. Dr. Kempe has been here several times in the past. She has really extensive experience as a pediatric health service researcher and clinician. Coming from Denver and Denver Children's Hospital, she has received several research grants in the field of immunization services delivery and involved designing and evaluating interventions to improve immunization coverage. She's published more than 30 original scientific manuscripts in this field. She established a vaccine policy collaborative initiative, a Sentinel survey network that provides rapidly access to vaccine-related knowledge amongst primary care providers, not only pediatricians, but family physicians as well. She brings in the perspective of a practicing primary care pediatrician to ACIP, and we're looking greatly forward to her contributions. Next. Cindy Pellegrini is the Senior Vice President in Public Policy and Government Affairs of the March of Dimes Foundation in Washington. Just as a historic note, March of Dimes actually had its start 75 years ago and founded by Franklin Roosevelt as the National Foundation for Infantile Paralysis. So we're hoping that during her tenure here, we'll see dramatic progress made toward the elimination of polio. Ms. Pellegrini is our consumer representative on ACIP, and from 2004 through 2011, she advanced the American Academy of Pediatrics advocacy agenda on a number of issues, including disaster preparedness and response, immunization, and environmental health. Since 2011, she has overseen the March of Dimes advocacy agenda at both state and federal levels. She has a long-standing reputation among child advocacy community and is a knowledgeable and unwavering advocate of pediatric health. So we're looking forward to your contributions as well. Next, we have Dr. Art Reingold, professor of epidemiology, and he is at the School of Public Health, University of California at Berkeley. Many of us have known Art from presentations here dealing with the strategic advisory group of experts and applications of GRADE through the World Health Organization. Dr. Reingold has worked for over 30 years on prevention and control of infectious diseases at the national and global level, especially in developing countries. He has a great deal of experience investigating vaccine-preventable diseases. He is a member of the World Health Organization Strategic Advisory Group of Experts on Immunization, where he has helped, again, develop the guidance on evidence-based recommendations throughout the world. He served as a liaison to our evidence-based recommendation working group, and he brings just a great deal of knowledge from his many endeavors in the past. So again, we welcome Dr. Reingold. So welcome to all three of our new members. Just a happy birthday. And following in Dr. Frieden's comments about the role of good evidence-based practice in medicine, at this meeting 3 years ago, we unanimously adopted GRADE. Next slide. Just in passing, just mention that Maalin was the last person to contract polio or smallpox in the world. And following that, he spent his time working to eradicate polio in Somalia. Unfortunately, he just died this past July at age 59 from malaria. But he used his example of being a vaccine refuser for smallpox and talking to families and vaccine-hesitant parents, trying to encourage the adoption and acceptance of polio vaccine in Somalia. And last slide here. Just a special thanks to all of our dedicated colleagues who went to very extraordinary efforts to make sure this meeting occurred as scheduled. So I think just a quick round of applause again for our CDC colleagues. And with that, I'll turn it back to Dr. Pickering.
Thank you, Dr. Tempe. One of the highlights of our meetings is our ability to interact with our international visitors. And today we have 4 international visitors that we'd like to introduce. Dr. Li is director of the China CDC National Immunization Program. Dr. Li attended the last ACIP meeting, and since then he has acquired information about the U.S. immunization program, especially for us, how ACIP works. Dr. Li has observed the activities of several ACIP work groups and will be at CDC for an additional 1.5 months. And any of you who have not met Dr. Li, I suggested you do so. He's an absolutely wonderful gentleman, and we've thoroughly enjoyed your being here. So again, welcome. We welcome 2 other visitors from China. Dr. Ya-Li Wang is from the National Center for Adverse Drug Reactions Monitoring at the China Center for Drug Reevaluation in Beijing, China. And Dr. Keely Li joins us from the Division of Adverse Events Following Immunization Surveillance of the National Immunization Program at China's Centers for Disease Control and Prevention, also in Beijing. And again, those of you, I suggest that you interact some with these 2 individuals I just introduced. My brief time with them, I learned a great deal about the systems in China, and we thoroughly welcome you here also. Also visiting us is a longtime friend, Dr. Nobukiyo Okabe. Dr. Okabe is currently the Director General at Japan's Kawasaki Center Institute for Public Health. Dr. Okabe is a former director of the Infectious Disease Surveillance Center of the National Institute of Infectious Disease. And Dr. Okabe, it's always good to see you, and welcome to the ACIP meeting. We usually have Ministry of Health representatives at this meeting from the WHO Pan American Health Organization. We do not have representatives this time, but at the next meeting we will have representatives from one of their representative countries. We need to provide information for future international visitors. And again, we announced this last time, but again, it's very important, so we will mention it again. Due to changes in the Department of Homeland Security policy, additional forms will be required for each meeting at the time an international guest registers. It is critical that international visitors complete and submit these forms as soon as possible following registration. And Felicia Betancourt, who is in the table at the back of the room, and our committee management specialist, will be able to help with any questions and concerns about this process. And again, the earlier this is begun to register for the next meeting, the better. The next ACIP meeting will take place at the CDC in this room on Wednesday and Thursday, February 26th and 27th. Registration for all meeting attendees is required and is now open on the ACIP website. So I think it's open today. You can register for the next meeting today, so it'll be finished, and we encourage people to do that as soon as possible. Registration for U.S. citizens will be cut off a week beforehand on Monday, February 3rd. Registration for non-U.S. citizens, the cutoff will be February 3rd. For U.S. citizens, it will be February the 10th. With regard to our liaison representatives, Carol Hayes will be representing the American Nurses Association, while Katie Brewer is on maternity leave, and from what we understand, Katie and her baby are doing very well. We request that all cell phones be turned off for the duration of the meeting. Topics presented at ACIP meetings include open discussion with time reserved for public comment, which ACIP members consider to be extremely important. Time for public comment pertaining to topics on the agenda has been scheduled following the afternoon sessions on each day. Time for public comments also may be provided prior to specific votes by ACIP to enable these comments by the public to be considered before a vote is taken. People who plan to make public comments should visit the registration table at the rear of the auditorium, fill out a brief form, and Felicia Betancourt can help you with that. People who make public comments should provide 3 areas of information. One is their name, secondly is their organization, and then lastly, any potential conflicts of interest. Disclosures. To summarize conflicts of interest provisions applicable to the ACIP as they are noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the ACIP committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or who serve on data safety monitoring boards may present to the committee on matters related to these vaccines. However, they are prohibited from participating in deliberations or committee votes on issues related to those specific vaccines. Detailed instructions for submission of names for potential candidates. This is the next to last slide that we want to show. The time is almost here for the cutoff, so detailed instructions can be found on the ACIP website. The cutoff is November 15th, and the term will begin on July 2014. And what is done, members are submitted. All CVs and applications are reviewed by a steering committee. 2 names for each position are then forwarded to HHS, and a final decision then is made about the new members. One last comment. At every meeting, we provide an update on the status of the ACIP recommendations. A list of recommendations is shown on this slide, and these are the recommendations that have been published since the last meeting. Links to these recommendations and schedules can be found on the ACIP website. The 2 that are not up there that are still in various degrees of clearance are the Haemophilus influenza B recommendation report. And again, an R&R is a large document, sometimes 40 and 50 pages, very inclusive. The second one is the Japanese encephalitis recommendations for children 2 months through 16 years of age. This will be what's called a policy note, and these are very brief, about 1,400 words. Having them brief allows us to get them published in a much quicker manner. With that, Dr. Temte, it's time for roll call and to request your conflicts of interest. Thank you.
Okay, and we'll just start out with Dr. Karen and go around clockwise.
No conflicts.
No conflicts.
Duchin, no conflicts.
Art Reingold, no conflicts.
Bocchini, no conflict.
Harriman, no conflicts.
Jenkins, no conflicts.
Rubin, no conflicts.
Going Beasley, my institution receives funds from Merck Pharmaceuticals for clinical trials.
Vasquez, no conflicts.
Lee Harrison, no conflicts.
Campus Outcalt, no conflicts.
Pellegrini, no conflicts.
Bennett, no conflicts.
And Temte, no conflicts. With that, I think we move straight on into the agency updates, and I will ask for Dr. Shuka to comment for CDC.
Thanks so much. I just first want to welcome everybody here and say that the most common question I got during the shutdown was, are we going to have the ACIP meeting? I feel like this is the Rolling Stones concert, and I'm grateful we did not have to cancel it. I have updates on 3 areas that aren't on the agenda. The first is about immunization coverage. Between July and September, CDC issued 6 MMWRs on coverage updates, including HPV, teens, kindergartners, toddlers, and influenza coverage. We have sustained high or increasing rates with the notable exception of HPV, and as you heard from Dr. Frieden, that is CDC's highest priority for urgent improvements in coverage. You'll hear more about some of the activities going on in that tomorrow on the HPV session. One fallout to the shutdown was we weren't able to have the Tdap in pregnancy session, and so I wanted to just provide a brief update. The statement on recommending Tdap in every pregnancy was published in February 2013, and at the June meeting there was an update sketching out the forward plans for this. But to summarize what is going on, CDC and FDA continue to monitor VAERS for reports. The studies in the Vaccine Safety Data Link, or VSD, have begun. We don't have any update on coverage available, though data through 2011 were presented at the June meeting, and those showed, as you may recall, in 2011, only 1.6% of pregnancies outside California in the VSD sites had Tdap administration. In California, 29% of pregnancies had Tdap administered. We believe things are better now, but not all the way better, and we look forward to updates on that. Initial safety data from the VSD sites is expected by the summer of 2014. There are pre-specified outcomes that they're looking at, but we don't actually have results from that at this point. The program is also developing a prospective clinical study of Tdap safety in pregnant women for the Clinical Immunization Safety Assessment, or CISA, collaboration. So that's what we can say about Tdap in pregnancy, knowing that there's a lot of interest in that and that the committee will be updated in the future. The third area I want to mention is federal support for immunization through the discretionary Section 317 program. You heard about the VFC 20th anniversary. The Section 317 program is the basis of our discretionary immunization resources. Like most programs during the era of budget pressures, we have to prioritize, and I want to repeat what our 3 top priorities are for the 317 funding. The first is to maintain the immunization infrastructure. That's the people and systems that support vaccine delivery, surveillance, and response to vaccine-preventable diseases, and developing and maintaining the evidence base supporting immunization policy that this committee reviews regularly. Second priority is modernizing immunization systems and supporting innovative technology through the many IT initiatives going on, including interoperability between electronic health records and registries, finishing our VTRAX rollout, et cetera. And then the last priority is maintaining flexible funding for vaccine purchase to fill gaps, which mainly would be uninsured adults and public health response to emergencies or outbreaks. Recently, we implemented a change in the state vaccine ordering policy to no longer permit state or CHIP ordering of vaccines that would rely on advancing credit from the 317 funding. But instead, we required states to have purchase orders before their orders could be placed through our VTRAX system for state or CHIP vaccine. We implemented this October 1. Health departments did an enormous amount of work to get ready for October 1 because we didn't have much time to implement it. But it turned out that it was just in time policy because we had worked on this and had a software update. Our new system meant that the government shutdown and lapse in funding for the 317 vaccine did not have to stop the ordering of state and CHIP vaccines. We actually processed state and CHIP orders for 800,000 doses of vaccine between October 1 and October 17th, despite no dollars in the 317 vaccine fund. We're working now with ASTO and NACHO on a working group to strengthen the collaboration around future program changes. This was a difficult one for the programs, and we'll be working forward on having more advance notice before such changes. Thank you.
Thank you, Dr. Shukit. Mary Beth Hans could not travel due to shutdown, so she has sent this in to be just entered into the record. In terms of Medicare flu vaccine data, this is from the Centers for Medicaid and Medicare Services. CMS has worked with the National Health Resources and Services Administration and the National Vaccine Program Office to post Medicare flu vaccination information for those in fee-for-service on the NVPO website. This is updated weekly. In terms of coverage of preventive services for adults currently enrolled in Medicaid, while the benefit package for adults who receive health care coverage under the Affordable Care Act is required to include coverage of preventive services, including coverage of all ACIP recommended vaccinations, states continue to have the option to cover preventive services for adults currently enrolled in Medicaid. The Affordable Care Act addresses this by including a provision, Section 4106, that provides an incentive to states who provide coverage for all ACIP recommended vaccines and their administration, as well as the Grade A and B U.S. Preventive Services Task Force recommended services. To date, 6 states have submitted a request to CMS to cover these services and receive the incentive. These include California, Hawaii, Nevada, New Hampshire, New Jersey, and New York. CMS continues to work with all the states to encourage coverage of preventive services. Department of Defense.
Yeah, good morning. Department of Defense has no new updates for this meeting. We continue to align our service-specific vaccine policies with that of CDC and ACIP. Thank you.
Thank you. We have next Department of Veterans Affairs, and Dr. Linda Kissinger is not here and has sent the following as an update. The Veterans Administration and Department of Defense continue to work toward information exchange of clinical data between our 2 electronic health record systems. The VA is working on certification of their EHR for meaningful use and has undertaken an effort to modify the underlying immunization file structure to address those needs. The VA is also involved in several pilot projects that involve exchange of immunization information with retail pharmacies. They have developed an influenza immunization mobile app that staff will be piloting this influenza season. The app is designed to provide an easy way to document administration of flu vaccine in mass vaccination scenario, such as a health fair. A few confirmed cases of influenza have been confirmed in VA facilities, and a total of 867,493 doses of flu vaccine have been recorded since August 1st. And that ends the update from Department of Veterans Affairs. Next, FDA and Dr. Sun.
Good morning. Just a brief update from the FDA. Since the last ACIP meeting, there's been some noteworthy approvals, amongst which are influenza vaccine, Flulavol, quadrivalent, which is approved now for those over 3 years old. The Flulavol trivalent has also been approved for ages 3 to 17, and we also approved the use of Menveo, which is a quadrivalent meningococcal vaccine for children 2 to 23 months. This year, so far, the strain change supplements for influenza vaccines include 4 quadrivalent vaccines and 5 trivalents. Thank you.
Thank you, Dr. Sun. Dr. Caserta from HRSA.
A very brief update. The notice of proposed rulemaking by the Secretary to add seasonal influenza vaccine as opposed to trivalent should be published in the Federal Register shortly, so it would be covered under the program. Thank you.
Thank you. Ms. Groom from Indian Health Service.
Good morning. Just a brief update on influenza activities with the Indian Health Service. We are starting to post our weekly influenza surveillance reports. Those are on our website. And to date, I don't have a specific number as the VA, but we've administered about 150,000 doses, which is about 15% of our patient population. And then a quick word on HPV, as that's clearly a high priority area. The Indian Health Service is undertaking an effort to work with our sites around HPV and doing some evaluation with our data and then targeting some of our sites for some specific interventions to see if we can continue to increase our rates.
Thank you. National Vaccine Program Office, and Dr. Gillen.
So we have a joint presentation here. I'll start with NVAC.
We had our recent meeting. The National Vaccine Advisory Committee approved a revision to the standards for adult immunization practices, a big change in the 10 years since the earlier statement. And this one is addressed, instead of one set of recommendations, there are recommendations to everyone, and then an audience-based set of standards for vaccinating providers who see patients but generally don't vaccinate, health departments, healthcare organizations, and others. The NVAC also approved a report from a global immunization working group that focuses in 6 sets of areas, including enhancing polio eradication and measles and rubella elimination, strengthening global immunization systems, enhancing vaccine safety monitoring, improving global R&D capacity, improving capacity to make decisions at global immunization committees or country immunization committees, and coordination of HSS global immunization efforts. There are 3 other working groups that NVAC is supporting. One deals with maternal immunization with the goal initially of improving current implementation of recommendations for pregnant women. That probably will be close to finalization at the February meeting of NVAC. And after that, they will look at barriers to R&D with regard to development of new vaccines for pregnant women. We also have a working group on vaccine acceptance/hesitancy, as well as improving HPV coverage, and they are actively working to try and address concerns to improve vaccination uptake.
So part 2 of the 1-2 punch. Just to reinforce about the adult standards, it's going to be published in Public Health Reports early in the spring. There's a summary table that's actually it's being produced now that I encourage you to take a look at. That'll give you an overview of of the details that Walt mentioned. Other things you've already mentioned, John, about the CMS mapping tool for adult influenza immunization for the CMS beneficiaries. It's not just on the NVPO homepage, but it's being featured on the HHS homepage, which is getting a lot of traffic these days. But I encourage you to take a look at it, because what it lets you do is to actually zoom in on a map and go find your zip code and see what's going on, particularly looking at racial and ethnic disparities. Just at the end of September, NVPO awarded to RAND a contract to focus on developing an adult immunization strategy and to develop an adult immunization strategic plan. RAND is the group that helped us with the National Vaccine Plan, so this really layers on top of that. Many of you will hear from them to get your thoughts about the directions that we should be taking. And then finally, there's been an effort that you've heard about before from the Institute of Medicine on a tool that they've been developing as a decision support tool on vaccine R&D priorities. They had a presentation here which was part of their beta rollout, which is you got screenshots of their software. Now you can actually look at their software. So I'd encourage you to take a look, go to the IOM website. It's called Ranking Vaccines, and have a look at that. And we and particularly the committee would be interested in your feedback about that. I think that's it for me.
Thank you, Dr. Ornstein and Dr. Gillen, and Dr. Gorman for NIH.
Thank you, Dr. Temte with the T. On September 23rd in 2013 in Bakersfield, California, the Centers for Disease Control and Prevention and the National Institutes of Health announced they will launch a randomized clinical control trial to get a better understanding on how to control coccidioidomycosis or valley fever. The trial will involve about 1,000 people diagnosed with community-acquired pneumonia, the most common presentation of valley fever. One half will be randomly chosen to receive a traditional antibiotic and a placebo, and the other half will be used an antibiotic plus fluconazole, an antifungal medicine usually used to treat valley fever. The patients will be tested immediately and then every 2 weeks to see if they have valley fever and which treatment proves to be most effective. Both Dr. Collins and Frieden, who were present at this announcement, said the trial will spread awareness about the disease and educate physicians, researchers, and patients about diagnosis and treatment. Inside of NIAID, Dr. John Mescola has been named as the head of the Vaccine Research Center. He was the acting director and before that the director of a core virology lab. His work demonstrated a protective role of antibody response in HIV infections, and that work helped direct the discussion of the development of HIV vaccines. On September 16, 2013, the National Institute of Allergy and Infectious Disease held a mini summit on adenovirus platforms for HIV vaccines. The participants were greeted and given their charge by Dr. Fauci. A meta-analysis of previous studies using adenovirus platforms in HIV vaccines was discussed by Dr. Folman. The questions of biological plausibility of adenovirus increasing HIV acquisition risk and whether or not this potential risk applies equally to all other potential adenovirus vectors were discussed. There was a spirited discussion of these questions as well as future research pathways that could be taken to answer the questions raised. A written report of that meeting will be forthcoming. On August 8th of 2013, an article was published in Science Online describing a malaria vaccine that was developed by the Scenaria Corporation and tested in the NIAID Clinical Center. The vaccine was found to be safe and effective and seemed to indicate that there is a dose-dependent immunological threshold for the development of malaria immunity. Getting down to the DMID area, on September 18th of 2013, the VTU sites initiated mix and match studies of the H7N9 vaccines with adjuvants. These trials will use influenza antigen from one manufacturer and administer this antigen either unadjuvanted, adjuvanted with MF59, or adjuvanted with ASO3. There are 2 trials. One trial will test MF59 alone, and the other trial will test mainly ASO3, but will have MF59 arms. The target enrollment for these 2 trials is 1,700 subjects. We are approximately 2/3 through the recruitment at this time. On September 26th, a new round of VTU awards were announced, and the list of the 9 sites will be in my delivered minutes. In terms of vaccines and pregnancy, for the last several years and in different vaccine and therapeutic areas, DMID has sponsored clinical trials that enroll pregnant women. While designing, implementing, and doing the data analysis of these studies, the DMID has identified multiple challenges specific to conducting research in these populations. To address these challenges, DMID continues to seek consultative input from experts in the fields of neonatology, perinatal medicine, PK, clinical trialists, and regulatory issues. During 2011 and 2012, DMID organized 3 consultative conferences in order to develop a template for protocol design of vaccines administered during pregnancy and harmonize assessments of adverse events emerging during these studies. The output of these meetings have been published in 2 related articles and an editorial in the Journal of Vaccine. Given the CDC's emphasis on HPV, DMID was also conducting a trial of what's actually an epidemiological study looking for the tweeners, people who start their process but don't complete it on time for HPV vaccine, to see whether or not their vaccines, I will call them alternate vaccine schedules, are equally effective to one that is presently recommended by the FDA. Thank you.
Thank you, Dr. Gorman.